Good morning. I wish to thank Jean-Louis, Sebastien, and the organizers for inviting me to participate in this seminar. I'm very sorry I cannot join you in person because I have another commitment in a meeting in Asia, but I'm really very happy in any way to participate, at least virtually, sharing with you some considerations on the role of blood pressure variability during sleep. These are my disclosures. And in my talk, I will briefly address these 4 points: the blood pressure variability phenomenon, how we can approach it, what happens in cardiovascular regulation during sleep, in normal condition, and when we have sleep alterations. And finally, what is the clinical relevance of this in terms of outcome prediction? Let's start with blood pressure variability. This is blood pressure variability. As you see, blood pressure is not a number, it is a series of waves, as you know very well. And we have to accept the challenge whenever we measure blood pressure that we are facing a dynamic phenomenon which is continuously changing in our life during the day and the night. In this paper that we published this year, we try to summarize what we know on blood pressure variability at the moment, considering methodological consideration, also practical issues related to the definition of blood pressure variability, the methods for its assessment, the mechanism behind the changes, and the practical clinical relevance of these phenomena. And we try to classify the different variability components into those having a shorter time window where they are expressed or a longer time window. So we go from within beat changes, the pulse pressure, basically the key element of blood pressure variability, the very shorter changes beat by beat, the short-term fluctuations that you can identify with an ambulatory monitoring over 24 hours, including hour-to-hour, minute-to-minute changes, and day-night changes as well. Then we have mid-term fluctuations that you can quantify using home blood pressure monitoring over 1 week. That's a kind of day-by-day variability. And finally, you may have the long-term changes that include fluctuation between seasons, between months, years, and this is also including the so-called visit-to-visit variability, which has been now in many studies reconsidered as an important predictor of outcome in treated and untreated patients. For the different types of variability, you might need a different methodological approach, but whenever you see an increase in any of these components, there is evidence that you also have an increase in the risk of cardiovascular complications. And what is behind blood pressure variability? Well, variability is the result of a complex interaction between intrinsic cardiovascular regulatory mechanisms and extrinsic influences, including environmental, emotional, behavioral stimulation. And all this is different in different individuals, depending on the kind of individual reactivity to all these factors. The result is a blood pressure variability phenomenon, which can be different in different subjects, depending on the complex interaction among all these factors. What happens during sleep? Well, we are used to consider sleep, as in this very famous Van Gogh painting, as a very relaxing time where everything is going to be smoother. And also in terms of cardiovascular regulation, we are expecting a kind of reduction in the intensity of all the activities, and definitely we consider sleep as a relaxing time where everything is going to be slower in a way, which is partly true, but is not completely true. And as you know, when you consider sleep, sleep is a complex phenomenon. That's classic hypnogram, where you can see that you may go from wake to deep sleep, but you may also have phenomena of REM sleep where the neural and cardiovascular mechanisms are quite different. During the night, in general, you have fluctuation in many parameters, hormonal changes, as you know, temperature changing, but also blood pressure fluctuation. And on average, we acknowledge that it might be just a reduction in blood pressure when you fall asleep as compared to the daytime. The cardiologists are quite interested now in the cardiovascular regulation during sleep. First of all, for a quantitative reason. We spend 1/3 of our life sleeping, which means that it's something we should take care of more carefully. But that's also important for us because during sleep, there are several neural mechanisms regulating the cardiovascular system, which undergo quite an important modulation, and we have evidence that many cardiovascular events may occur differently at different time of the 24 hours. Some are more frequent during sleep, and some others more frequent during the wake time. And in specific conditions such as coronary artery disease or heart failure, we know there are important cardiorespiratory alterations during sleep that might affect the clinical condition of our patients. We started taking care of what happens during sleep by using this method, the intra-arterial blood pressure recording in ambulant subject developed in Oxford by Professor John Pickering in the 60s. This is an invasive device which can collect beat-by-beat recordings for 24, 48 hours. And as you can see from this typical recording, in 24 hours, you have more than 104,000 values. You can identify all the changes occurring during the wake or the sleep, and you clearly see the difference between wake and sleep in terms of blood pressure, either when the sleep is during the night or during the afternoon when you take a nap. Of course, that's an invasive approach, and we need something non-invasive, so we also use in our experiment the portable device developed by Gianfranco in the 80s. And this device has been tested and validated by us in cooperation with our Dutch friends, comparing the intra-arterial with the non-invasive beat-by-beat recording. And you see quite a correspondence in the assessment of the blood pressure fluctuation over 24 hours by the invasive, the red line, and the non-invasive, the yellow tracing. And you can see here small vertical bars at the bottom, which are markers of the shift between fingers, which is done automatically by the device to allow too long compression of the finger in which you are recording the signal. This is the paper where we perform the validation against the intra-arterial line. But let's go back to the detailed changes during sleep. As I mentioned before, of course, when you go from wake to deep sleep, there is a reduction in pressure. But when you focus on REM sleep, for example, here the thicker line, you see that also the blood pressure recording is thicker, which means more beats, higher heart rate, but also higher values. So there is a diversity of modulations of the cardiovascular system in the different sleep stages. And when we try to consider the autonomic regulation during sleep with our method for the spontaneous baroreflex assessment, the sequence method, you find clearly the orange squares that during the night in normal people there is quite an increase in the baroreflex sensitivity, the sensitivity of the cardiac control by the baroreflex, which is associated with the reduction in blood pressure variability, the yellow squares. So the baroreflex sensitivity and the blood pressure variability, systolic variability in this case, have an inverse association all over the 24 hours. And this is very clear in the young individuals on the left here. Different colors refer to different measures of the spontaneous baroreflex with the up or down sequences or the spectral approach. On the right, you see what happens in the elderly. With advancing age, this function is less efficient, and the modulation of the baroreflex is less clear between day and night. And this might be responsible for some problems these people have when taking the orthostatic position, maybe during sleep, because they cannot quickly adjust the cardiovascular control as done in younger individuals. But this requires in continuous recording, which is not available in a clinical setting. So we have to accept and use the classic discontinuous ambulatory blood pressure monitoring, which is nevertheless able, as you see, to provide evidence of a modulation of blood pressure between day and night. And this is the case also for heart rate. So even if imperfect, you still can get information on what happens to blood pressure and blood pressure changes between wake and sleep. And you can define your patient as dippers or non-dippers depending on whether they have or they don't have a reduction in nocturnal blood pressure compared to the daytime. But what happens in case of sleep alterations? Well, this is our typical patients. Male subject, age 55 to 60-year-old of the abdominal obesity, is a drinker. You see, he was drinking some alcohol during this short flight. In the pocket, there is a pack of cigarettes, and he's sleepy. That was a 30-minute flight, and he fell asleep after 5 minutes from takeoff. So nocturnal problems might justify daytime somnolence, and this person might have all the cardiovascular risk factors lumped together to justify an increasing cardiovascular risk with the possibility of hypertension, diabetes, metabolic syndrome, some inflammatory condition somewhere, organ damage, and obviously autonomic dysfunction. When this person is going to sleep supine, he might easily have an occlusion of the upper airways, so an obstructive apnea, and the repeated occurrence of oxygen desaturation is modifying the cardiovascular regulation. If you combine this with continuous blood pressure recording, if you zoom into this, you clearly find a correspondence between reduction in oxygen saturation and blood pressure rise. These are 5 minutes of recording. You have 6 apneas, so it's a severe sleep apnea patient, and there is quite a clear evidence of an increase in blood pressure variability due to the variability in oxygen saturation. At the same time, we measured in this patient the baroreflex sensitivity with our method, and you clearly see a reduction in the sensitivity of the reflex control of heart rate when you have apneas, the pink bars, as compared to control individuals. This is clear in the wake phase, in the non-REM and REM sleep as well. But if you focus specifically on the association between oxygen saturation and blood pressure changes, you can learn quite a lot. We did this study some years ago, and we tried to combine these two phenomena. On the left, you see a recording with normal respiration and normal oxygen saturation. On the right, you find a short time, 200 seconds, reflecting what happens during one apneic episode, oxygen saturation going down, and when you start breathing again after the apnea, blood pressure is going up. If you zoom and you have longer time window, you have seen this slide before, 5 minutes, again, you find the clear association between these two phenomena. And even when you are widening the time window from 6 minutes to hours, you find the same phenomenon again. In this particular case, you find that the highest oxygen saturation during the recording was associated with the lowest blood pressure, and vice versa, the lowest oxygen saturation was accompanied by the highest blood pressure level. Again, demonstrating a kind of association and inverse link between fluctuations in oxygen and fluctuations in blood pressure. We try to model mathematically these phenomena through the spectral approach, and here you find the power spectra of systolic blood pressure fluctuation on the left and oxygen saturation on the right. And you find the peak in the relatively low frequency area, which was the frequency of apneas in this specific individual. So we try to calculate the cross-spectrum modulus between oscillation in oxygen saturation and oscillation in blood pressure, and we computed this as a mathematical function, which is quantifying how much the blood pressure, the systolic blood pressure in this case, was changing in response to a unit change in oxygen saturation. We call this cross-power index, which is a measure of the impact on blood pressure of fluctuations in oxygen during the night. So using 2 fingers, basically, we have a quantified and calibrated blood pressure recording, and you have simultaneously the oxygen saturation ongoing, and you can quantify the cardiovascular impact of apneas easily in your patients. But this, again, requires the continuous recording, which is very useful in a lab. You can demonstrate the physiology of this. You can combine this with sympathetic recording, with the microneurography, and you know very well that during sleep and also in the wake time, patients with sleep apnea do have a sympathetic activation, but all this has an impact on the blood pressure profile, which is usually assessed in the discontinuous manner allowed by the classic ABPM devices. And even in this case, you can see a lot. Again, in this patient, you find normal pressure during the day, in the office, at home, but a clear increase in pressure at night at the time where there was oxygen desaturation repeatedly occurring because of sleep apnea. Again, combining then some pathophysiological approach to something possible in a clinical setting, you can understand more cardiovascular pathophysiology in your patients whenever they have sleep-related breathing disorders. And in this position paper some years ago, in collaboration between the European Respiratory Society and the European Society of Hypertension, we strongly emphasize the need of monitoring blood pressure at night, which should be done not only in the diagnostic phase to identify the blood pressure changes associated with apneas, but also in the treatment phase. When you try to remove the apneas with CPAP, for example, you want to see corresponding changes in blood pressure. But be careful. Going back to a continuous recording, here you find 4 episodes of blood pressure rise due to apneas. If you have a discontinuous recording with measurement every 30 minutes, as you can see in this example, we were able here to identify only one of the 4 peaks, because the discontinuity of the recording was not able to follow in details all the changes. So having continuous recording would be better. That's why we now have a lot of interest in the new technologies for cuffless blood pressure measurement. We published this position paper last year, and we are analyzing the different possibilities offered by technology, but admittedly, there is a need of validation. None of them has been validated according to internationally acknowledged validation protocols without involvement of people from the company. So that's a task for us as investigators to provide this kind of validation, to be able to understand whether we can use these new technologies. Finally, what is the impact of all this on outcome? Well, there was a change in the cardiovascular field. Recently in the Lancet, there was a series of papers emphasizing the importance of sleep disorders in terms of cardiovascular health. Sleep was considered a kind of Cinderella branch of medicine in the past, now is gaining more importance. And in the US, the president of the American Heart Association was redefining the life's essential. There were 7 until last year, now there are 8. And they include diet, physical activity, control of glucose, control of weight, control of lipids, blood pressure, no smoking, and now also good sleep. That's important for cardiovascular health. And this is important because we showed years ago that if you have something wrong during the night, you have changes in blood pressure. That's a CSTO study, a study on isolated systolic hypertension in the elderly. And in a 2-year follow-up, we were able to show that there was a quite an important increase in events rate linked to blood pressure elevation, but the link with office pressure was weak. It was closer with daytime and 24-hour blood pressure. The best was with nocturnal blood pressure. And if you focus again on the continuous recording and not focus on blood pressure variability, you may identify protective and damaging components. The protective component of blood pressure variability are the changes when you fall asleep, the reduction during sleep at night or even during the day. The other faster fluctuation due to reaction to different stimuli are possibly damaging components, which was demonstrated in the frame of the Pamela study, where in the population north of Milan, 2,500 people followed up for more than 12 years, we found an increase in cardiovascular death when there was a reduction in dipping at night, in parallel with an increase in short-term blood pressure variability. And if you focus specifically on the night, you see in the nice paper by Paolo Palatini that an increase in nighttime systolic or diastolic on the right blood pressure variability is associated with a higher events rate as compared to individuals with a lower nocturnal blood pressure variability. So these phenomena are important. What is then the conclusion of my quick talk? We are used to consider cardiovascular risk factors, dividing them among those non-modifiable or modifiable. And in the modifiable group, now we might add to obesity, smoking, diabetes, hypertension, whatever, also sleep disorders, because they are important and they can be improved. Targeting sleep then might be the next frontier in improving cardiovascular health. If you are aware of the impact of different sleep problems on blood pressure control during the night, change in dipping, prediction of event. That's a Spanish study here on the right that was showing nocturnal blood pressure as a best predictor of outcome when compared to daytime values. We might learn how to better support and help our cardiovascular patients. But admittedly, we need more studies. We need evidence for randomized controlled trials that if you are improving blood pressure variability also at night, this is improving outcome. Now, we do not have this evidence. We have evidence from observational studies on the association between increasing variability and problems with cardiovascular events or diseases. We need to demonstrate also the reverse. And that's our task for the future. We are working on this, and we are also open for collaboration. If you want to join us in this endeavor, this is our hospital and university building in Milan. Milan was quite in a difficult position for the COVID, you remember, a few years ago. Now we are back to light with the mountains on the back, as you see. And you're welcome to visit us. If you want to get more information, that what I could give you quickly in this presentation, you are really welcome to write me anytime. Thank you again for the invitation. Thank you also for your patience in listening to my talk.
So we have some time for maybe some comments or questions to the key opinion leaders present in the room. But I think that the talk reflects both the usefulness of assessing variability of some cardiovascular parameters on the prognostic of our patients, but also highlights the caveats of the measurement techniques, the importance of sampling frequency, and also the need for further validation of some available device that will be maybe soon released to the market. No question, Vincent? So if there is no question or comment, maybe Jean-Benoît?
Somebody knows something about the potential cortical activation produced by the cuff during the period of inflation. Do you have some data about this?
We had very frequently this discussion with the cardiologists, but we are not very open to look at, because it's going to be an additional limitation, I think, of the use of the currently available tools. So yes, there are some quite old studies showing that there are clear microarousals during the night and some alteration in sleep architecture when you are measuring 24-hour ambulatory blood pressure measurement.